So the question is frequency of urination and incomplete emptying. How do we manage that, and how does that relate to what we've been talking about? The urinary system, as I said earlier, has two functions: storage and emptying, and that's all that it does. So when a patient complains of frequency or urgency, that can be one of the two, but it's not guaranteed as to which one it is. So if a patient has had some kind of surgery that would lead to scarring, we have a high index of suspicion that scarring is the underlying source of the problem, and the mechanism by which that's causing the problem is the bladder is not able to empty fully. So you're getting a degree of urgency incontinence because the bladder is actually full and the receptors are telling the brain that it has to go because it's full. And so you'll get contractions of the bladder that you can't, or the patient can't, suppress because the bladder is so full. The other factor is that as the bladder gets full, as we talked about, then the pressure builds up and you get overflow incontinence in that situation. If you attack each of the individual components of the problem, so if there's a narrowing, open up the narrowing. If there's a degree of bladder instability, address that with medication. So gradually you can whittle away at the factors that are causing the problem and at least get improvement. Not always possible to get complete resolution in those cases because they can be very tricky, and dealing with scar tissue is an extremely, extremely difficult problem.